And we're live. Take it away,
We
Sarah.
are live. Hi, everyone. I've got Sharon with me today, and we have an extra special guest on, John Hennessy, who I'll ask to introduce himself in a moment. But we're so excited about our Tea Talks because what we're proving is when you have a little bit of time, and you really want to dive into something that either you're aware of or you're in the market for, or something brand new that you're learning about, either by choice or to expand the things that you're knowledgeable about. This is such a great show because we come to you as we are, as do our guests, as we are. There's not rehearsals, there's not advanced questions. It's really just us in our normal day to day. So we want to just say thank you so much to our audience who has been so supportive in these early stages of Tea Talks. And we want to say how much we appreciate all of the feedback we've been getting, either when you watch us live or on the replay. So don't forget, if you haven't seen past episodes, you can always go, if you've got 10 minutes to spare, and check into that replay. So as I mentioned, we've got a special guest, John Hennessy. John, thank you for being here with us.
Thanks for having me. I'm excited about this. Now that we got all the tech figured out.
Yep. Well, John, tell us a little bit about who you are and what you do.
Sure. So, John Hennessy, I'm currently a principal at a company called Valuate Health Consultancy, and what we're all about is making sure patients get the medicine they need. And we do that in what's called a market access space, which is working with our customers, whether they're pharmaceutical companies, diagnostics, providers, anything, to make sure that they have coverage for the medicines they offer for patients. And I come to that having spent about 20 years working in the delivery of oncology in physician office settings, hospital settings, academic, community, and a little bit of time focused on the payer side as well. So I've had a really fun career that has allowed me to have kind of a unique perspective, I hope, on sort of the challenges that all of us face getting patients, getting caregivers, getting providers, really the whole ecosystem to work in the best way for patients.
You know, John, one of the things that we I think as an industry, we underestimate is really knowing the patient voice, meaning we all work, whether it's for pharma, diagnostics, education, in the clinic, and we all think that we're working on behalf of the patient. And when you actually meet and listen to patients, your mind gets blown in so many ways. I say that because I always see what you do on the highest level, and I'm always like so impressed. But recently I saw your posts on Young Survivor Coalition, and I realized, like, you don't just talk about it, you are about it. You serve with them, you understand their needs, you listen to the voice of the patient. And I think that that's probably what makes you such a powerful advocate, because you know the intersection between doers and people that are living the experience. So talk to us just a little bit about, like, a little deeper dive into how you represent the various audiences that you serve and how all of those things work in tandem to give you the strongest voice.
Yeah, it's great that you mentioned that. We had the Young Survival Coalition Summit back in February, I think, and if I get that wrong, someone will certainly put that in the chat. But for me, it's sort of a yearly, when we have them yearly live, the opportunity to be with patients, to be with caregivers too. And I think we have to remember that patients and caregivers, while they are a tandem, they have different needs, they have different preferences, different attributes mean different things to them. But that's an invaluable experience to do that. And I think particularly, I have to remember my experience as a patient, as a father, as a son, as a friend to people who've experienced cancer. I've taken opportunities I spent a week a couple of years ago down in Mississippi during the COVID surge with a FEMA deployment to spend time with the people on the front lines, understanding sort of what their needs and opportunities are. And I think that's really important, that we understand the challenges from the bottom up rather than just looking from the top down. I think you can have, really smart thinking, but you have to kind of put yourself in the shoes and listen to what's important to folks making these decisions. And they're making decisions often with imperfect information. And we often think about, well, we've seen this trial, we've seen this evidence. Well, for people who are struggling to understand terms like deductible, coinsurance, coverage, things like that. We've got a long way to go to help them establish preferences and to talk to them with their caregiving partners, with their physicians, to get what they really need and what meets them where they are, not where we choose to give them the services we have.
It's so important. Everything you're saying, I think, is so important from both sides. And today, as we're talking about financial and logistical challenges for patients, your mind tempts you to go to people at or under the poverty line. But the reality is that middle class, working class, even people of significant wealth can in one generation have medical bankruptcy.
Mm-hmm.
And we think it's somebody else's issue until we're the ones with the diagnosis or we're the ones with the catastrophic injury. So talk to us a little bit about where you want to start or what you want the takeaway from this tea talk on financial. If it's the only thing someone leaves with, where do you want to leave us with information on how you can understand, how you can get financial literacy when you're going through a diagnosis?
Yeah, so I'd almost take it one step back, and once a year, most of us have the opportunity to pick a health plan, and most of us pick a health plan based on what's going to come out of our paycheck, and that's reasonable. But most cancer patients, when they're newly diagnosed, didn't pick a health plan based on I might get cancer. They
Right.
picked a health plan based on other attributes. So, given that, what I think is probably the most important thing is if you look at the economy and figure that 18% of GDP is healthcare spending. When we're doing our own budgets in our own households, we ought to expect that we're going to have that sort of healthcare spending. So, what I tell my kids, what I tell other folks is, if you've elected a high deductible health plan, use your HSA.
Yeah.
It's there for a reason. Take advantage of this thing particularly. I think the second thing is to think in advance about what's important to you and how you might make decisions. And I think that's challenging. But we have a lot of therapies, particularly in oncology, where you've got a lot of incremental expense from a patient and caregiver standpoint, and not so in sort of a limited benefit. So you're gonna have to start thinking about those things. I think it's hard to do that prospectively. The other thing is this isn't just about co-payments and deductibles. It's about making utility payments. It's
Yeah.
about food insecurity. It's about that you want to put your kids through college. Are you putting that money at risk? Are you putting your retirement at risk? And I think your point is well taken. That it doesn't take much to put people in that jeopardy. I reflect back on my experience running an oncology practice, and we were very good at telling you exactly what your out-of-pocket costs were going to be. And then we kind of moved past that to say, you know what, really for oncology patients, the question is, what's your out-of-pocket maximum? That's what you can expect to spend this year, whether it's here, whether it's there, whether it's something else. I think what we forgot to do was ask, can you afford this?
Yeah.
Really approach it from that fashion rather than, the line item detail is, are you going to have a challenge affording this? Are you going to have to make some choices you don't want to have to make? And so I think it's really at some point very early in the journey, giving people the tools to start making these decisions, making these choices that we don't want to make, but I think we have to. I think is really important because without good information, I think people, sometimes make decisions they regret. And I'm sure all three of us know someone or have friends who looked back on that journey and said, if I had known this, I might have made a different choice.
Yeah. So, oh, sorry. Go ahead, Sharon.
I was just going to just say, as you were talking, Jen, I was thinking about my own journey as a patient, as a cancer patient. And I remember when I moved to a different state from Florida, I had to get new insurance. And what I thought I was buying, I thought it was insurance. Of course, I wasn't planning for anything catastrophic. And I was paying a pretty high premium for what ended up being kind of like a fake insurance. When I got diagnosed and it was time for surgery, that's when I knew it wasn't going to cover anything. But what I really appreciated was the doctor's office telling me where to go get insurance. It was she says, here, go on this number, call this number, go on this exchange, and it covered everything. It covered everything. And so I'm just wondering, how can we also help doctors help to inform patients? Because again, I was fortunate because that's where I got the information.
Yeah, I think it's a great question, and there's some limitations there. In a physician practice, when I have a contract with Blue Cross and United and Cigna, I really can't say you should pick this or that. But what we did every fall was we knew there was open enrollment coming for Medicare, and we had a policy that our financial counselors would reach out to our patients and say, "Hey, you know, you've got a choice to make coming up. Here's what you can expect, or what we think you might expect during the next year. Make a choice within those confines, right? Understand and be thoughtful about it rather than waiting until the last minute and picking the lowest premium or doing something that just is very reactive." We try to do that, certainly in the work we do now when we think about practice support, is what can we do to give practices the tools to help people meet these needs as best possible. It's challenging, but I think, again, part of this, you have to go back to fundamentals. If between the terms copayment, coinsurance, and deductible, probably somebody, maybe half the people who are looking for insurance don't understand what one of those terms is.
Right.
And then we start thinking of out-of-pocket maximums and things like that. So I think the first thing is to de-jargonize
Yeah.
what we do. There was a great study looking at shared decision making, and physicians who've been trained in shared decision making having conversations with patients, and they thought they were on it, and they found that we still use jargon when we're having conversations. So I might say to you, "Well, your OOP is the thing you ought to worry about," and you'll nod your head, but you may not know what OOP is.
Yeah.
Is it out of plan? Is it out of pocket? So I think it's, there's some fundamental education there. But I do think we're seeing more physicians, and particularly when you think about folks concentrating on total healthcare costs, understanding that those decisions that people make when they're in there sort of picking their insurance plan are really vital for people. But I do want, what I love to have is practices like New England Cancer Specialists up in Maine who figured out that the food insecurity was a problem. And once they did and started addressing it, they found that what they thought was a small problem was actually much bigger. But the fact that they asked the question and started talking to people about it gave sort of permission for patients to have that conversation, solved a whole lot more needs than they even thought they were going to need to solve.
What you're saying is so important. So many things, starting with you have to know your audience. Number two, your audience has to know that they have options. Like, you think about even younger people, and especially now that we've got younger people being diagnosed with more aggressive tumors, more aggressive cancers, when you're in your 30s and you're starting your families, you're looking for the lowest price. Like, when they boil it all down, it's like, what's my family practice care copay? What's my pharmacy copay? Beyond that, I don't think people are looking for ambulance rides. I don't think people are looking for catastrophic coverage. I feel like talking to people and saying, pull out that plan that you signed up for and scrutinize it and ask yourself, what if? You're not creating these false scenarios. You're preparing you and your family for things that happen to everyday families where you have control. And it's like, if you look at the difference between the lowest tier and the highest tier, it might be $75 a month, but $75 a month for peace of mind for people who are able to pay that can be the difference between a bankruptcy and not. So I love that you're giving the audience that. And then secondly, for patients that are living in it, Molly McDonald said this great question or post: financial toxicity is more acute when treatment side effects result in lost income and inability to pay basic cost of living expenses. Like, the reality is, so many Americans live check to check. Yeah. So you lose a week of work, that translates into grocery bills. That translates into your light bill, your kids' football. Like, that's real money. So John, help us to understand, like, once you take a look at that policy, what's the next step as a person who hasn't experienced illness? And then maybe what's the first step of someone who's recently diagnosed? How do they have to know their policy and what it covers? And like Sharon said, maybe fill in the gaps of things that it's not covering.
Yeah, so I think a couple thoughts. One is there was reading someplace that half the people in the country have selected or prefer a high deductible health plan. Well, they prefer because it's cheap, not because that's the kind of coverage they want. So, particularly for folks, I think that's a reasonable trade-off for people to make, particularly young people to make. I mean, there are people who unfortunately get diagnosed when they're young. A lot of people don't. And so
Yeah.
I think we have to respect that, some people are going to make a decision, a reasonable one, saying groceries or give, Blue Cross more money, and they're going to opt for the groceries. Now, that said, you need to be thinking about this out-of-pocket maximum, and that's the number I think that's the most important.
Okay.
Because, particularly if you have a chronic illness, it may not be your doctor where you're going to pay it or the ER or someplace else, but throughout the year for everything that's going to happen, that's sort of the number to pay attention to. That's what I do with my own coverage. I say, what's our out-of-pocket maximum? And I fund the HSA to make that happen. I'm fortunate to be able to do that. I know a lot of people are not. That said, we have a whole bunch of people who, in the next 12 months, have had Medicaid coverage, and as we know, Medicaid coverage is going to be reevaluated with the end of the COVID health emergency. They're going to have to make some interesting choices. Do I go back to an employer plan? Do I take an ACA plan with tax benefits? And so these sorts of questions I think are really important. But I think it's worth noting that for most people, I think you hinted towards this, it's not the out-of-pocket costs of care that are forcing the bankruptcies. It's not being able to work. It's the caregiver not being able to work. It's not being able to return to work. And what we do see, the University of California, San Diego had a poster at the ASCO Quality Conference this year, and it looked at the insurance choices of folks who have cancer. What do they do in their next opportunity to enroll? And you'd think, wow, they've got cancer, they're going to select a very high quality benefit plan. Well, that's sort of what you would like to see happen, but they have the economic issue on the other that forces them maybe to prefer a plan with lower benefits because that's what they can afford from an out-of-pocket cost standpoint. So one of the things I think is important for us to do is give people the tools to make the best decision, but we're going to have to respect what those decisions are. And particularly with certain social groups and we have a very diverse country. So it's very hard to say, you need to select this. But what we can say is understand what your choices are, what they mean to you, what they mean to your family, and make good decisions that way. We tend to get very focused on who we are. There are people, a lot of people in single parent households. They have a very different set of decisions to make than my wife Tracy and I do. There are people who live in multi-generational households who are taking care of parents and children. Totally different set of decisions to make. And so how do we give people the best tools to make the best decision for them rather than telling them what we think their best decision is?
I have a question, John. What are your thoughts on the ACA? Do you think, I don't know if you can get granular with that, but do you think that works? I mean,
yeah, I mean, it works with a little W. Yeah, I think it works with a little W. I think the fact that people can get access to healthcare who have pre-existing conditions is really important. I mean, bar none, that's the thing that's most important. I think the A in affordable, we can certainly agree is a little A and not a big A.
right.
The benefit plans are many of the bronze plans are kind of bare bones plans. Is it better than having nothing? I think it is. To your point earlier, there are a variety of health coverages out there that really aren't very comprehensive. And I think as the more we get into, sort of serious chronic disease where we have some amazing therapies out there that are life-changing therapies for folks, but these non-traditional health plans don't cover them or cover them in an incomplete basis. I think one of the things I worry most about is sort of, as you described, these health plans that aren't really health plans. They're sort of, we've talked about these temporary plans and maybe, making these more available because they're less expensive. Yeah, they're less expensive, but they cover less.
Yeah.
The folks we're talking about who have cancer, have other chronic diseases, that simply doesn't work. So yeah, I think the ACA it's got some things that are very valuable about it, but the central problem is that healthcare is expensive in this country. And we haven't made a decision that everybody has a right to healthcare. And that's going to make these decisions difficult for the foreseeable future.
Yeah. We have a question from the audience. It's actually a question and then a follow-up. Sorry, this is my little guy. He comes home from school at this time every day. So question is, what are the most important questions patients should ask at the start of their treatment? And the follow-up to that is the person asking this question, Peter, he says, my wife had a $12,500 annual out of pocket. I was really surprised by that number. So it kind of two questions. What are the most important questions patients should ask at the start of their treatment? And then also, how do you find that out-of-pocket estimate? And then is there something you can do about it outside of open enrollment, or is it something to look forward to when open enrollment starts again?
I'll start with the first question, which is what should we do at the start of treatment? And what I would suggest is take a step back. Before you start treatment, what are the questions you're asking about your choices? And I think being very clear about that and understanding that that's not a one and done type of thing. You can, particularly folks, we talk to folks in metastatic disease, that where we're going to continue treatment until for some reason someone chooses to stop. That decision you make on day one can be revisited in 60 days, in 180 days, rethinking about that as your preferences change, as your experience with the treatment changes. But I would take a step further back and say, before you make a decision on treatment, do you feel like you have all the information you need? And in the practice I ran, I know Sammy has been posting on here too. Sammy worked with me at the practice. One of the things we did was we had a waiting period between the time we had the consultation and the time we started therapy. And in that period, we would have our patients meet with a nurse practitioner because we knew there would be questions that came up and people might make different decisions having had time to reflect. So the first thing I would do is what my old speech teacher taught me in high school, which is just to pause.
Yeah.
Do not feel like you have to make a decision immediately. And I think people, either because they look at their caregiver or they look at the physician, and there's this, sort of interesting, relationship between patient and physician that neither one really wants to let the other down.
Yeah.
So sometimes you look at the physician and says, we're going to do A, and you say, well, the doctor wants to do it, so I must want to do it. You kind of have to take a step back and say, what's important to me, and bring the caregiver into that conversation. So for me, that's the first step before you even start treatment. And the whole idea behind shared decision making is you have to kind of get a sense of what your values are and what you think is important, and make sure you're communicating that with the person who's prescribing the treatment, and make sure you're both on the same page there. In terms of the out-of-pocket costs, the first place to look is your SBD, your summary of benefit design, and it'll be there relatively prominently. The second thing is, once you pick yourself up off the floor, when you see what your out-of-pocket maximum is, and say, okay, two things. One is, can I afford it? And second is, if I have to spend that money, how will I make that happen? Most providers will give you some opportunity to take advantage of either existing charity policies or payment plans or something like that that can make this manageable. I tell people the worst thing you can do is just not respond at all. There's some really good programs out there that I think we're familiar with. $1 I think does wonderful work helping patients take advantage of charity programs that exist with providers that they're seeing. I think RIP Medical Debt is another organization that helps people sort of dig themselves out of holes that are not dig outable on their own. And I think you can certainly sit back, and I think it takes a fairly high degree of medical literacy to, someone says, well, look at your bill line by line. I have trouble doing that, and I've been in this business for 35 years. So I think that's something that's very tough to tell someone and say, hey, you need to look at your bill line by line. But I think, taking a deep breath, I think at open enrollment, that's, for me, it's one of the most important numbers that I look at when I'm selecting a health plan, when I'm telling other people to do that. But there are other times where I'm going to look at things like narrow networks, which if you're someone who sees a lot of doctors, that can be maybe more important to you as to having a broad network. And I'd rather have that high out-of-pocket cost, and that's okay. That's your choice, as long as it's an informed choice and not something you make at 11:58 p.m. and the enrollment deadline's in 2 minutes.
Yeah. No, excellent. I'm going to switch to this thought Sammy just sent. We had Rick from Sharon, remind me.
Life, we call it life after work. Life after. Yeah.
Where life after, where they get patients back to work after a cancer diagnosis. But Sammy's point is actually working with and after a cancer diagnosis. She says keeping cancer patients working is one of the biggest needs I've seen professionally in my work in exercise oncology exercise. Supporting areas such as energy, function, cognition, and emotional health are essential in our work, along with making sure patients and caregivers have resources and support. So one, I want to say I live with a chronic autoimmune disease. I'm in the category of people who probably need to know a lot more about my plan. biologics can cost $11,000 an injection, and we take it weekly forever.
Right.
So we've got brain issues, we've got bone issues, we've got joint, you name it. But one thing, as Sammy was saying, that is so clean and clear is there is an intersection between these areas of like what doctor is prescribing, what you can pay for, and personal responsibility of managing your lifestyle health, movement, food, stress, reduction. All of these other things help us as individuals mitigate some of the things that might have to be managed financially or therapeutically. John, talk to us a little bit about keeping patients at work, and then how that plays into financial challenges that you may have while you're going through your therapy.
So I'll say two things. One is keeping patients at work. The other is, I think, keeping caregivers at work as well.
Yeah.
When you look at the financial toxicity data, sometimes it's the caregiver's loss of income that is sort of the straw that breaks the camel's back. And so in each of these cases, you're looking at the trade-off of, in many cases, how effective the treatment is versus what the treatment does to you. A classic example of this in oncology is neuropathy. There are a number of therapies we have that lead to that being a side effect. Well, if you need to use your hands, you need to be on your feet. If you're a concert pianist or just, typing in and doing, other tasks on your keyboard, neuropathy can lead to a lack of ability to do your job. And I think that's part of the conversation you have with your doctor and saying, listen, I get that this therapy could theoretically be more effective for me, but I need, and quite frankly, I want to keep working. And we've talked about the economic value of work, but think about how much work means to us as people. For many of us, work, for me, I love what I do. If I were told I couldn't do what I do, it would be really bad for me. So making sure I'm making the case for that. And in for many treatments, we do have choices. We can go down a path of less side effect, or sort of different side effects. What works for you? What works against you? What prophylaxis can we take advantage of that might cost a little bit more, but can avoid losing work and things like that? And again, it's elevating this conversation, as we said earlier, before you start treatment. What's important to you? Well, it's important to me that I stay at work. It's important that I don't become a burden on my caregivers or my families. Okay, now that we understand that, here's maybe a different set of choices or a different set of weights we might put on things to allow that to happen. But that's, again, it's all about, that's a perfectly reasonable choice for someone to make, that I would prefer to do work and have a greater sense of ability. And either we, adjust the treatment for that, or do sort of things like Sammy does, which is, okay, I know you're getting this treatment, I know you have this disease, but that doesn't mean we sit around and wait for things to happen. We can still take an active role in our own lives. And that gets to your point of personal responsibility, but we also have to make sure people understand it's an opportunity there. And the stuff that Sammy does, I've done work with folks in the oncology rehabilitation space, all about, this isn't the end goal of any treatment isn't just that I got your dose in. The end goal is I get to whatever my new normal is, and I learn to appreciate that and take advantage of it, and have a life, a high quality of life. And we can all define what that is differently, but we also can sit down and see, well, I know what not high quality of life is. And if you're worried about food, if you're worried about where your next, how you're going to pay rent every month, I don't care how good your treatment is, that's not high quality of life.
Yeah. Sharon, I'll give you the last question. First of all, John, if we had the time, we'd be sitting with you till 8 o'clock.
Yeah, I know.
But I'm already thinking, like, we got to book John 20 more times, like maybe a recurring guest spot, because we could go through so much. But Sharon, I'll give you the last question, and then John will give you the Tea Talk tell all for you to give us something happy about T cells. So Sharon, go ahead.
As John was talking, I was thinking to ask both of you, like, if you're not watching Tea Talks, right, and hearing this great information, I'm thinking to myself, how are patients being educated about all of these things? What Sammy's saying, what you're saying, John, it's a head scratcher for me, and I can see why the uninformed patient has such poor outcomes, because we've discussed so many things today that could truly, impact in a positive way a patient's outcome. But gosh, are they hearing it? And I'm just thinking, what a challenge we have in informing patients. Just even just small conversation, like, wow, so much we can do to take control, but
quickly, I'll give you an anecdote and an answer. I think an anecdote was not long ago, I was working someplace and they were developing this 2-inch binder for patients of all the information they needed. And you knew that the patients took that home and stuck it someplace, and
yeah,
good luck, Charlie. I think what we do need to figure out is how do we meet patients where they are?
yeah,
Not tell them what we want them to hear, but figure out how to give them information when they're ready for it, and to get it in a timely fashion so they can make their best decisions with it. And again, you don't have to make that best decision right away. You can make that best decision in 60 days, and 90 days, 180, as you learn more and as you experience more. So I think that's all really, it's all we can really do. But I think as long as we are receptive to what they need and being there where they want us to be, we'll be more successful than if we just produce a bunch of stuff and let Chat GPT just throw information at folks. That simply doesn't work.
yeah.
It doesn't, and it also doesn't work, John, because you're not meeting people at a coffee shop. You're meeting them at a place where they have lost most, if not all, of the control of their emotions for this moment.
Yes.
You have given them a word, cancer with a big C, that all they think about is all the people they know who have died. I mean, that's the first thing you think about. And then you're thinking about your children, your partners, your everything that goes along with it. And then you get the 2-inch binder. I mean,
Thanks.
it's too much. It's too much. I want to just point out, Molly McDonald posted, I love the work of advocacy because, you know, if not them, who? Really, if not them, who? So at Pink Fund, we have a just diagnosed poster which gives them all the questions to ask. It's available on the website, www.pinkfund.org. These are people who have walked through the fire. So you really, you know, you have to just give them kudos for making it available for those of us who haven't yet. So John, at T Talk, we called our little talk T Talks because T cells, as you know, are life-giving fighting cells. So we always ask our guests to give us something good to leave with. It's a Monday. In South Florida, it's a gloomy, rainy day, John. So I'm depending on you for some good T cell stimulation.
Wow. You know what I enjoy about what I do is that every day, if you keep your eyes open, there's some good news out there. And whether it's good news about therapies, good news about opportunities for treatment, good news about, you know, just good stories about patients who have had a good experience, and what can we learn from that? How do we tell other people about it? So what I would encourage everybody here is to stay open to that, to look for those things and figure out how you can use that to tell a story that will help somebody else or help an organization change their approach so that they're focused on what's best for not just the patient in front of them, but all the patients in their community. And that's what gets me out of bed every Monday morning, Tuesday, Wednesday, Thursday, Friday as well. We know it's tougher on Monday, but I think the fact that those opportunities are still out there is what really, you know, motivates me and keeps me excited about coming into work every day.
Oh, we love it. John, we love it. We loved having you as a guest. As Sharon said, you know, the work you do is just incredible. And we hope that we can continue to be a platform that shares work like yours. Total Health, as an educational organization, we're the largest provider of free oncology medical education. You know, there's really amazing medical oncology providers out there. But during COVID, we made the decision, everything is free, and we haven't turned back. Why? It becomes a global resource. It becomes a patient resource. It becomes resources to people on the healthcare spectrum that never thought they could access a $699 CME, a pharmacist, a medical assistant. So for us, being able to reach our, 50,000 learners, we would love to partner with you and the work that you do to help inform our people on how they can best empower patients exactly where they are when it comes to financial literacy and beyond. So hopefully you take us up on you becoming a recurring guest.
Yes, that would be great. Love it.
Wonderful. And thank you so much for being here and giving us the word that you can find something new and good news every single day.
Awesome.
All right. Have a wonderful Monday. All right, guys.
Bye. Take care.